මට ස්ලයිඩ් 72 ඉඳලා ගන්න මුලින් ඉඳලා නෙමෙයි ස්ලයිඩ් එක. හරි.
මේ ඔලිම කඩු කරන්න.
උඩට. වලින් අඩු කරලා දාන්න. 0 කරන්න.
අඩු කරන්න.
0 කොට නේ වැඩි.
සර් දැන් මේක සර්ගේ ප්‍රසන්ටේෂන් තියෙනවා නේද?
එතන යනවා කියන්න 70 කීරස යනවා
70 මම මේක ඇති හොතෙල්ල බලන්න 84 ඉඳලා බලන්න
84 එතනින් ගාස එනවා මේ ස්ක්‍රීන් එකට ගිහලා ෂෙයා ගිහලා සර් ෂෙයා කේස තියෙන zoom app එක ඒකෙන් සර් ෂෙයා කරන්න තියෙන ක්ලික් කරලා පස්සේ yes දෙන්න yes දුන්නා පස්සේ ස්ක්‍රීන් එක ෂෙයා වෙනවා zoom එකට
හරි එතකොට මම මේකෙන් යන්න පුළුවන්
ඔව් එතකොට මේකෙන් යන්න පුළුවන් සර් දැන් කොහොමද ඩිෆෝල්ට් ගන්න ෆස්ට් ස්ලයිඩ් එකකින්
ෆස්ට් ස්ලයිඩ් එකකින් නම් ගන්න සර්
ස්ලයිඩ් එක මෝල් කරන්න
එතන පෙන්නනවා හරක් ගාලා යන්න පුළුවන් නේද
නෑ නිකන් මේක මෙහෙම උඩට ස්ක්‍රෝල් කරලා යන්න පුළුවන්
යන්න පුළුවන් සර්
view කරන්න එක
එනවා
ඔගොල්ලෝ ඉන්නවනේ හරි මම වහන්නද මේක
ඔව් ඒක දැන් වහන්න
සර් ඔක එතන අරගෙන ඉඳලා
මම අර තන ගෙච්චර කවන්න නැහැ නේද අර මෙතන තියාගත්තා හරි
Yes, we have two very eminent and popular speakers with us who would be sort of enlightening us on these subjects. Dr. Udita Bulugahapitiya would sort of update us on the insulin initiation in type 2 diabetes patients. And Dr. Tilak Silva would help us to understand how to manage the smoking patient. Dr. Udita Bulugahapitiya, MBBS, MD Colombo, MRCP UK, FRCP Edinburgh, and FCCP, and consultant endocrinologist, Colombo South Hospital. Currently, he has had many positions in his professional career over the last several decades, and he had been the secretary of the Ceylon College of Physicians for 2 consecutive years. And he is also a council member of the Accreditation Council of the Ministry of Health and the founder president of Sri Lanka College of Endocrinologists and the first editor of the Sri Lanka Diabetes Endocrinology and Metabolism. He's also a trainer and examiner in endocrinology and general medicine. He is board certified as a consultant endocrinologist and got his board certification in 2004, and is a member of the Royal College of Physicians UK MRCP since 2007. So fellow of the Royal College of Physicians, Edinburgh, and Ceylon College of Physicians, American College of Endocrinology, and Sri Lanka College of Endocrinologists. And Dr. Udita Bulugahapitiya, his main interest includes endocrine and non-communicable diseases, and published several research articles in peer-reviewed journals, including Diabetes Care, European Journal of Endocrinology, Diabetes Medicine, and Endocrine Abstracts. He has done a number of research presentations in international as well as local fora, such as European Congress of Endocrinology, Endocrine Society, American Association of Clinical Endocrinologists. Sir, I would like to invite you for the podium to deliver your lecture.
Good evening, ladies and gentlemen. Let me first thank the college for inviting me to be a part of this session. And I was just discussing with them what exactly for me to talk to you. But finally, we thought that we will talk about insulin initiation, especially in type 2 diabetes, because it's a common disease. And what I thought was that I'll go through with how to initiate insulin. But when we come to question and answer session, you can be open to any of the diabetes or endocrine conditions that you are interested in. It's not moving. Okay, move that. It's not moving here. This one.
Yes. Yeah. No, other. Constant. Yes.
Right. Okay. Thank you. So, ladies and gentlemen, all of you know that diabetes is a okay. So, diabetes is a major epidemic in world over, and we are also facing a same situation here. If you look at the world situation in diabetes, it's going to be almost doubled in next 15 years time. And, probably around 450 million to around 700 million. And most of the countries in type 2 diabetes is going to be rising. And this rise is commonly seen in probably developing or low income countries than developed countries. I think that is the most important thing that we have to understand, because our health budget is so that we have to probably spend a lot of money into manage diabetes, as well as if you don't manage diabetes properly, probably management of complications of diabetes is going to be hugely a costly issue. And If you look at the diabetes atlas, again, you know that if you look at this South Asian region is going to be the, highest increase in diabetes over next 15 to 20 years of time. And therefore, when you look at the other countries in the world, there is also going to be an increase. But when you consider the South Asian countries, there's going to be a major increase and going to be double in type 2 diabetes in next 15 to 20 years time. Therefore, you and I are going to see most of these patients in time to come. And all of you know that because of this current COVID situation, majority of the diabetes having a huge risk factor of dying with diabetes because of its complications. And if you look at the latest publication in Lancet with diabetes and COVID, you will understand the huge risk that you encounter if you have diabetes in this particular situation. If you look at I don't know whether you can see. If you look at the first 10 countries in the world having diabetes, the highest number of patients who are having type 2 diabetes, that you will understand that there's a change from 2019 to 2030, 45. Like initially, now if you look at the China and the US are going to be heading, but in 2025, 2045, 30, 45, China is going to be topping, and then the India is probably second. And also, if you look at the Pakistan is in 10th level, is going to come up into about 7th. And if you look at the first 10 countries in the world, there are about close to 4 to 5 countries from Asian region. Therefore, in one hand, type 2 diabetes is going to be a major Asian disease that you and I are going to see majority of the patients with diabetes and its complications in future. If you look at the Southeast Asia separately and age-wise, again around 8 to 10% in most of the countries. Currently, there are about 8 to 10% of patients who are having diabetes, and therefore, if you look at the millions and patients of having diabetes, you will understand that there's going to be huge. And if you look at the male-female differences, there is no major difference between either you are a male or a female, whether you are going to get type 2 diabetes and its complications. Therefore, whenever you get diabetes, that gender issues are no more, and you are having almost same risk of getting type 2 diabetes as well as its complications. So still into the Southeast Asia situation, and Sri Lanka is actually now probably the latest studies we have seen about 20% of patients who are having diabetes in urban situation in Sri Lanka. That's going to be 1 in 5 having diabetes in urban situation. But even if you go to the estate sector, where you get the most active people in our society, still about 8% having diabetes in the estate sector. So I think therefore, urbanization causes increase most of these non-communicable disease because of the available facilities are more. The Sri Lankan situation, all of you know, if you just you can actually calculate the number of adults having diabetes, because if you look at the latest the prevalence about 8.7, so we are going to probably having a huge numbers having diabetes. And if you look at these patients, fortunately not exposed to COVID, because of our most of our elderly patients are at home and they are not exposing to the risk of COVID. Therefore, that's why we are probably having low risk of death in COVID, because these issues. And other thing is that obesity is also a huge risk factor for type 2 diabetes as well as COVID. And if you look at the recent deaths, even in professionals who die very young age, around 30 years of age, biggest risk factor that patient had for COVID was the obesity. So the obesity is also a huge risk factor for all of these. So if you look at ethnic wise in Sri Lanka, you will understand that the Tamils are having slightly lower risk of getting diabetes. I think because of their eating patterns, Muslims are probably having higher risk because their eating patterns and the exercise capabilities are probably less than others. And probably you see that. But educational level and other factors are also having a part. But now we see there is no major difference with the education as well, because you have more comforts and more facilities. Therefore, you will probably have more prevalence of diabetes. If you look at the complications of diabetes in Sri Lanka, when you compare, you know that when you look at the complications of diabetes, the commonest cause of death in diabetes in Sri Lanka as well as world over is a heart attack. That's what we try to manage diabetes to prevent the first heart attack. That is the most important. The second most common cause is the stroke in diabetes. But when you look at the other Western countries, PVD and things are quite common in the Western countries. But when you come to Sri Lanka, peripheral vascular disease due to diabetes are less commoner than the other complications with diabetes. So if you look at the most of these guidelines, the ADA guidelines, if you look at it, when you start with metformin, if there are no contraindications, and we know that there are some other medications are coming very, very close to metformin in terms of probably getting the first option in another 2 years time, it might change. But for the moment, metformin is the first option in whatever the diabetes, type 2 diabetes that you are looking into. But when you select the second medication, there are loads and ways and means of selecting the second medication, but I won't probably, if there are a question, I'll answer that. But if you look at the second option in these guidelines, you can start anything as the second option. You can be a sulfonylurea, you can be a glitazone, you can start a SGLT2 inhibitor, you can start a GLP-1 analog, or you can start a gliptin, or you can start insulin. So the first is metformin, second is anything you think that appropriate for that patient. But when you select in the second medication for diabetes, I think it is extremely important, because then you can select according to the exactly the patient risk factor and the patient's lifestyle. Then you can select the best medication as the second option in time to come. Then the third option can be the anything else, that if you are selecting insulin, then it can be sulfonylurea, it can be again any of the other medications that you can select. Therefore, now even the bariatric surgery has come as the second option in managing type 2 diabetes. And we as the Colombo South, we are actually now operated about 400 patients with obesity with bariatric surgery, and we have good data in terms of curing type 2 diabetes in obese patients. Now, even if you look at the AAC, guidelines, again, almost the same. Metformin as the first option, and second option can be anything else. And there is slightly a change, because that they have categorized into a HbA1c level, and then how you look at the second option. But I really don't think that's a very, very practical manner of looking at it, because we as doctors be able to select the second option according to your HbA1c when you look at that. If you look at the drugs in the management of type 2 diabetes, we know that insulins were like 1920s, first the animal insulin was identified. Then after that, huge changes of insulin has happened, and almost everybody who got the newer insulin had got the Nobel Prize for the science, and that's how it has progressed. Then metformin has about more than 60 years of experience in type 2 diabetes. That's why it is still hang on the first place, because of the huge data available for metformin. And then other medications up to what is SGLT2 inhibitor, which is probably probably one of the best medications available for the clinical practice at the moment. Therefore, we have huge number of tablets as well as injectables to select when a patient sit in front of you, and that depends on patient's preference and also the risk factor of the risk factors that the patient has got. So when you look at insulin, ladies and gentlemen, when to start insulin is a question that majority of the people ask. And we know that if a patient has severely hyperglycemic episodes, like coming with loads of symptoms, and sometimes with complications like infections, or sometimes in an acute situation like in an ICU setting with a myocardial infarction or whatever, at that time it's a good time to switch into insulin, because you can have a quick changes in the doses and quick results you can get it. Because you know that if you start tablets, it gets about 6 to 8 weeks to act, and you are not going to get any result in weeks time. But when you start insulin, the next hour we can see the difference. So in any acute situation, if you want to have a good control, the insulin is option. And at the same time, pregnant, yes, metformin we can use in pregnancy, but then you can use other options as insulin. And also the patients on high steroids, whenever they are sometimes in multiple myeloma and things, they are going on cyclical steroids, and therefore patient needs cyclical insulin at the same time to deal with it. But the commonest time that you and I prescribe insulin is when the oral hyperglycemics are failing. And sometimes in 2 medications, sometimes go to 3, sometimes we see 4 medications and failing, and then we are starting insulin. So there are ways and means of starting insulin. Nothing is wrong, but I think it's a good thing to understand that what is the appropriate time to start insulin is the most important thing. Early insulin, there are some data. We know that when you get type 2 diabetes, the most important time of the type 2 diabetes, the first 5 years. If you deal with first 5 years with strict control, and you are like less likely to get complications within next probably about 20 years, because the metabolic memory that you're going to create in a patient. Therefore, not most people think that more important time is when you get a heart attack or a stroke to manage, or when you get a complications to manage. No, when you get the type 2 diabetes at the first stage, you need to look and do the tight control as possible. Here you see that when you have a 8.5, you get into the 6.5 level and try to continue the strict control continuously, not allowing the blood sugars to go up and then again acting. So proactively, you have to looking into diabetes and get the control continuously less than 7 or less than 6.5. But if you allow the blood sugars to go up and then act, then probably the damage is happened, and there you get more and more complications. That's what the UK PDS showed. If you start early, do strong control early as possible, and the better outcome in microvascular as well as macrovascular complications that you are going to get it. And again, most of other larger studies like VADT and all these studies showed that if you late control, nothing much you're going to get. Even if you have a strict control at the latter stage, no much of benefit that you're going to get it. Therefore, early start, either insulin or tablets, give a strict control. That is the most important thing. And this is the UK PDS study. You understand it study had gone to 8 years, 8 to 10 years. What happened was all these patients were newly diagnosed type 2 diabetes. They had strict control arm and a less strict control arm, and then they followed up for 10 years, and they showed that at the end of 10 years they showed a reduction in microvascular complications significantly. But what they did after that was they didn't have this control in both arms. They didn't have a strict control in the one arm. They just follow up these patients for next 10 years without a good control. And after 10 years, they understood that patients who had a strict control in the first 10 years had a huge benefit in terms of microvascular complications as well as the macrovascular complication. That's what you call a metabolic memory. Therefore, the strict control at the initial stage of the disease is the most important thing, not after 10 years, which was shown by UKPDS very clearly. So UKPDS very clearly shows that if you reduce HbA1c 1% less than usual, then you are reducing about 20% of the deaths related to diabetes, 37% microvascular complications, even heart attacks by about 15%, and you reduce your amputations by about 40% and strokes by about 10 to 15%. So that is if you do a 1% reduction in HbA1c early as possible, not at the latter stage. And if you allow the blood sugars to go up and up with early stages, then you are going to get more microvascular complications, more macrovascular complications, and that stage getting a strict control is not that beneficial. So what are the evidence on adding insulin onto the oral drugs? Now, if you look at the benefits of adding insulin, probably if you wait very, very late on oral tablets, what will happen is beta cell destruction happens continuously, and you will end up with very, very little beta cell reserve. When we diagnose type 2 diabetes, what we know is 50% of the beta cells are already gone. So you have to live with another 50%. Therefore, if you just allow the blood sugar control to be poor, the biggest the toxicity to the beta cells are the glucose toxicity and the lipotoxicity and the glucose variability. Those are the three things that you create in a patient to destroy your beta cells. One is a glucose toxicity. When the blood sugars are high, you are destroying your beta cells. When the lipids are high, you are destroying your beta cells. And other one is the more important thing is the glucose variability. If you increase blood sugars coming down again like zigzag pattern, when you sometimes use a sliding scale in hospitals, what you do is the blood sugars are 300, then give a high dose of insulin, then blood sugars are like 40, again you give glucose. It's commonly happening in the hospital setting, which is called glucose variability, which also causes death of beta cells. So for you to keep the beta cell reserve, you should not wait very late into start insulin. And also when you are in insulin, you can probably have a better control if you proactively change the doses properly. And also probably when you have good control, you are having less microvascular as well as macrovascular complications, probably a good quality of life when you have a good control. And therefore it's also benefits. But what are the challenges in starting insulin? The biggest problem is the weight gain and hypoglycemia and the injections. And if the patient is gaining weight with insulin, you are in the wrong track continuously, which shows that although the patient doesn't get a hypoglycemic episodes, those are asymptomatic hypoglycemias. That's why patient is gaining weight. So patient who is on insulin should have a stable weight unless you are on a wrong track. And if you look at the short term use of insulin. Now, when you get type 2 diabetes at the initial stage, if you start insulin at the first option without any tablets, these are the the systemic review and meta-analysis of this kind of patients. Like type 2 diabetes, first diagnosed, you give insulin at the first option, and pool data shows that if you start any insulin initially and get the good control, their beta cell reserve will come back to a reasonable better level, and also their insulin resistance goes down. And that is what this meta-analysis have shown very clearly. And if you look at the short-term insulin systemic review further, you will understand that if you give initially insulin type 2 diabetes, there's about 60% percent of the patients will be without any medication for about 3 months. And even if you take 24 months, 40% of the patients were not on any medications for 2 years. So it's a major change. And if you start insulin initially, sometimes you can, up to about 2 years, you may not give anything to the patients. Patients can be cured with diabetes or remission in diabetes for next 2 years. So that we need to keep in mind, and a lot of data is coming up in this particular thing as well. But currently, what is the commonest use of insulin is when you have type 2 diabetes, you start tablets, you get on with a good control. When the tablets are failing, you think of starting insulin. That's the commonest to start with. And usually when you're on 2 tablets or sometimes on 3 tablets. But more important thing is whenever you starting the 3rd tablet in type 2 diabetes to get the HbA1c less than 7, you need to understand that your beta cell reserve is extremely poor. Then you probably need to tell the patient that your beta cell reserve, patient start losing weight. Whenever the insulin is not there, beta cell reserve is poor. When you're on tablets, patients start losing weight. If the patient start losing weight in type 2 diabetes, that suggests that the very poor insulin reserve, and probably you need to think. And when the HbA1c is more than 7 continuously, yes, that's the time to start. When the diabetes is more than 5 to 10 years, then that is the time that you need to think of discussing with the patient at least to start insulin. So when you start insulin, when the patient is on either 2 tablets or 3 tablets, I think the best way is to start with the basal insulin, because patients are usually unhappy to start insulin when the patient is on tablet. But when you start about basal insulin, it's going to be a 1 injection, and it can be very flexible manner we can give, because if you start insulin as 2 doses, then usually you have to relate to their meals, and it's going to be a bit of a difficulty for a patient to get an insulin just before meal or a half an hour before meal is going to be a bit of a concern. But if you say, why not you take insulin at bedtime, majority of the patients will accept, because bedtime is quite easy, and bedtime can be even 8 o'clock, 9, 10 o'clock, even a midnight. That's fine. So the patient can take it. So With the oral tablets, the basal insulin is the best. Majority of the patient will accept insulin at that point, and then you can actually change the insulin regimes when the blood sugars are failing. And this again, I have shown you how the insulin has, progressed over time with human insulin, and we never see human insulin, the animal insulin now. Then the NPH insulin came into act. Then you get the synthetic insulin, either rapid acting insulin or a basal insulin that is synthetic. And now we have gone into the glargine insulin. Glargine uh, 300 is also available now. U100 is the initial glargine which you and I are using at the moment. Now the glargine U300, as well as you have a degludec insulin, which is registered in Sri Lanka at the moment, which is quite costly. But these two insulins are almost more than 24-hour action. Now, when you use NPH, that is either humulin N or a insulatard, that is the NPH insulin. When you use NPH insulin, you have to understand that's not a 24-hour insulin. It's around 14 to 16 hours. So whenever you start that insulin, like bedtime insulin, around like 3 o'clock in the next day, there is no insulin in the system. Therefore, your pre-dinner blood sugars are always high if your NPH is one injection. That's the fact that you need to understand. If you're on NPH insulin, the time that you should check the blood sugar is before dinner, because that's going to be high, because that time the insulin is not there. So that is important in NPH insulin. So the best insulin would be, if the basal is going to be 24 hours like that, that is going to be best. And if you the mealtime insulin, it should be cover all 3 meals like that. That's going to be the best physiological way of giving you insulin. And insulin analogs are like there are short acting analogs which are rapid acting insulin. They can be given just before meals. You need not to keep the time gap between the meal and the insulin injection, because they're rapid action. Therefore, the analog is a rapid action. Then you have a basal insulin also, which is almost 18 to 24 hours of action. So when you look at the different types of insulin, you will understand these are the rapid acting insulin, very quick action, and goes off very quickly on the system. Therefore, there is no problem after the meal. And the short acting insulin gets some time to act. That those are the human insulin, like humulin R and the Actrapid. Those are the short acting human insulins. You need to give half an hour before your meals because they are not that rapid acting. And if you have an intermediate type of insulin, which is the human basal insulin, this is the NPH insulin, then you have two types of long-acting insulin, determia and glargine. If you head-to-head trial with determia and glargine, glargine is closer 24 hours than determia, and there's a head-to-head studies available. And then the degludec insulin is more than 24-hour insulin, and U300 is also closer to the degludec insulin. Those are the insulins available for us when you start initiating this insulin. And if you look at why we use basal insulin, I think the first thing you need to understand is very, very well accepted by the patient, because one injection, and you can also give a very, very flexible manner because less hypoglycemia with basal insulin and less weight gain with basal insulin, and it is easy to take. For I think basal insulin is one of the best to start with. I always start with the basal insulin, then go for the prandial insulin, and then go for the premixed insulin, and finally you go for the 4 insulin injections. And if you look at most of these guidelines, will suggest that when your blood sugars are poor with 2 medications or 3 medications, next option should be a basal insulin. And this is the same thing that I have shown here. And therefore, when you have options of metformin, you can immediately start basal insulin with metformin if you want, but commoner way or a cost-effective way, probably after about 2 oral medications, if the patient is failing your HbA1c targets, then probably introducing the basal insulin is probably a cost-effective way, as well as the patients will get benefited by that. So how do you start basal insulin? If the patient is on oral tablets, I don't think that you need to do anything to the oral tablets. You can continue almost all the oral tablets without any problem when you start a basal insulin. You start basal insulin at the bedtime is one of the easiest ways to do it. And usually you can start about 10 units at bedtime, or you can start about 0.2 units per kilogram body weight. I think 10 units is probably a straightforward way of starting it. And then the patient need not to come to see you. Ask the patient to titrate the insulin at home. You can titrate at least about 2 to 4 units every 1 week if your fasting blood sugar target is not achieved. Usually fasting blood sugar target is around 90 to 130. So if you are not, if ask the patient, look at the fasting blood sugar in about a week's time, and if that is not in 90 to 130 range, increase by about 2 to 4 units. Every week patient can increase and then come and see you in about 2 months time. Then the patient's fasting blood sugar target is achieved. And therefore it's easy. Patient need not to come and see you, and patient can titrate at home when you start this insulin. What you need to understand is when you give basal insulin, it actually counteract with the hepatic glucose output in the night and between meals. That's how the basal insulin usually acts. Mealtime insulin only act when you eat and when the glucose exertion happen after you eat. But in between meals and overnight, what will happen is there is a hepatic glucose output, and therefore the blood sugars can go up. So the basal insulin will counteract this mechanism, and therefore that's how it works. So when you have a patient is on a oral medications and your fasting blood sugar is high and your postprandial blood sugar is high and your HbA1c is high, when you start basal insulin, what will happen is you only plan for a fasting blood sugar target, because whenever you get the fasting blood sugar down, your postprandial blood sugar automatically comes down. So you need not to look at the postprandial blood sugar or HbA1c. You just go look at the fasting blood sugar and get the fasting blood sugar down, then automatically other blood sugars will come down. Postprandial blood sugars automatically come down to targets, and when you get the fasting blood sugars to a target. I think this is very important to understand. When you look at HbA1c, higher the HbA1c, your impact uh, to the HbA1c is the biggest with the fasting blood sugar. I think this is very important to understand when you start basal insulin. If your HbA1c is 12.5, actually the major impact on the HbA1c is the fasting blood sugar. But when your HbA1c is like 7.5 and 8, then we're closer to the target, the more impact is the postprandial blood sugar, not the fasting blood sugar. Therefore, you can see that this international study, it's the Asian study, both shows the same. Higher the HbA1c, higher impact with fasting blood sugar. So what you need to, when you have a high HbA1c, what you need to concentrate is only the fasting blood sugar. But your HbA1c is closer to the target, that means 7.5, 8.5, then you have to more concerned about postprandial, because then the more impact on HbA1c is postprandial. Therefore, if your blood patient has fasting blood sugar of 110 and HbA1c of 10.5, there is some problem with HbA1c. Before you treat, you know that there is a problem, because that is not compatible. That is definitely not compatible. Therefore, when you look at this concept, when you look at the blood sugars, you know whether these blood sugars are correct or not, whether your HbA1c is correct or not. And if you look at basal insulin versus biphasic, so mixed insulin twice a day versus prandial insulin, when you compare all these three, actually, if you look at this study, least hypoglycemias and least weight gain is with basal insulin. That is obvious. When you're on a twice a day insulin, you are higher risk of running for hypoglycemia. Why? When you're on a twice a day insulin, you are getting insulin for the breakfast and dinner, and your major meal is lunch, and either you are going to get more high blood sugars there, and when you increase it, you are more prone to get low blood sugars if you are not your lunch on time. So if you're on a biphasic insulin, your lunch should be on time all the time. And prandial insulin always causes increased weight gain, but basal insulin is the least weight gain and least hypoglycemia that you need to understand. Therefore, ladies and gentlemen, if you look at early, if you look at this treat to target study, you will understand this gives you a target to start basal insulin. Usually, if your HbA1c is between 7.5 to 10, the basal insulin is enough for you with your oral medications. That means if you're on a 2 medications or if you're on a 3 medications and the patient is doing exercise and diet properly, and your HbA1c is 14.5, basal insulin has no place. Basal insulin has no place because it is beyond 10. Therefore, who really needs basal insulin, you can decide on your HbA1c because of this treat to target study, which has shown very clearly. And if you look at the treat to target study, you will understand weight gain is minimal when the patient is on metformin, but weight gain is slightly higher when you are on other medications. So that is obviously you can understand. Therefore, ladies and gentlemen, when you start basal insulin, I would say that you can continue any other medications with that. You continue metformin, you can continue sulfonylurea, you can continue gliptins, you can continue SGLT2 inhibitor without any problem. And you need not to discontinue anything. But if you're on a glitazone kind of things, you can consider, but still in some patients, still you can continue because glitazones had shown problems with bladder cancer, but it almost disproven with the prospective studies now. Therefore, still you can continue if you really think that's needed for the patient. Therefore, when you start basal insulin, start about 10 units or 0.2 units per kilogram body weight, weekly increases, and get the fasting blood sugar target. When the fasting blood sugar target is achieved, then you can go for about 3 months and do HbA1c. And if your fasting blood sugar is in target, and if your HbA1c is high, that means you need a second dose of insulin. That is because your postprandial is now high, because your fasting blood sugar is on target. That is the time you add the second prandial insulin, a short-acting insulin to the basal insulin, or you can go to a pre-mixed insulin twice a day. So whenever the fasting is achieved, HbA1c is high, then the second dose of insulin need to be considered. That's how you go from basal insulin to prandial insulin to premixed insulin, and then think about what other options are there. So I think that is how the starting insulin with basal. Then next option is the prandial. You can go for the second prandial as well if you want. Then 3 injections are there. That's not worth for me. I always think it's not worth giving 3 injections with a basal with another two prandials. So whenever one prandial is okay, but when the second prandial is initiated, better go for pre-mixed insulin because you can it is cost effective when you go like that. All of these studies have shown, all of these guidelines have shown the same thing. Start with basal, going to the prandial next, then the next is pre-mixed insulin. So when you are starting insulin, I think it's important that you educate the patient that the insulin is important, because majority of the patient thinks that you are come to the last resort of diabetes, or the worst situation of diabetes, because that's why you are starting insulin. There's nothing like that. Insulin is just another stage in diabetes. Patient has not come to the end of diabetes or the worsening of diabetes. That's only one stage of diabetes, and that needs insulin. So unless patient think that is a last resort, nothing else that we can do after it. There's nothing like that. The insulins are very safe, and you need to advise that to the start the dose, and always we should avoid hypoglycemia. Hypoglycemia is a terrible experience in diabetes. If you get hypoglycemia one episode, these patients are going to be poor control for lifelong, because they are avoiding that the experience all the time by eating. Therefore, they get a poor control. So keep hyperglycemia is better. If you produce hypoglycemia, the long-term control is going to be extremely poor. They have to be careful. So when I have already told you that how to continue the other tablets when you start insulin, and the biggest challenge in starting insulin is probably because it's an injection, therefore given a convenient time, then it's easier for the patients, and also the risk of hypoglycemia is the other problem. And if the patient is gaining weight for any reason, you should understand that you are in the wrong track. You need to rethink about dosing. And we always see that patients' weight is gaining continuously. HbA1c is like 10. We are increasing insulin continuously. Wrong track, because patient is gaining weight and higher HbA1c. That means you need to rethink about the dose of insulin. Come down, get diet and exercise to act, and then only you can achieve the blood sugar control. So reasons, if you look at why we delay insulin, probably, but there's a doctor's factor as well. We are unhappy to start insulin because it's a lot of work, a long time. You need to discuss with the patient, and then the patient will also be unhappy. And sometimes, patients have fear in starting insulin. I think in very short time we'll be able, we should be able to discuss with the patient and say this is one of the best options. And always when the patient is on type 2 diabetes and oral tablets, you have to on and off tell the patient one day you will end up with insulin. Then that discussion is very easy when it comes to the starting insulin. So decision making is not that difficult. I think if you correctly discuss with the patient the option of insulin, types of insulin available, and if it is not going to affect the day-to-day work of the patient, and if the patient is going to have better quality of life, I think the patients will probably start. And unless patient will lose weight, poor blood sugar control, get complications, and their quality of life is going to be extremely poor. Then I think optimizing blood sugar control when the patient is on insulin is important. Regular monitoring at home with glucometers, and advise the patient how to change the insulin, because patients should not change the tablets at home, because no point of changing tablets will not change your blood sugar. Some people come and tell me that, when he eats more, he takes too metformins. There is no action at all. You can't take tablets double the dose when you eat more, because it takes about 4 weeks to act if you increase the doses of any of these tablets. But insulin, yes, you can increase the dose, decrease the dose the way you want. Therefore, ladies and gentlemen, in summary, I think when you initiate insulin, try to initiate at the correct time, at least when the patient is on going into the third oral medication. At least at that time is a good time to start insulin. That will create patient to reduce the long-term complications. And if you start initially with the basal insulin, continue the oral tablets, and get the patient to monitor at home and get the best control. And when the control is losing, either go to a prandial insulin monodose or a pre-mixed twice a day, and then the patients will be better option. So I think the most important thing that I want to tell you is make sure that you start insulin at your level, not to wait, because unless patients will get poor control and come to us with complications like a heart attack or a stroke, then nothing much can be done, because the most important thing is to start early as possible and get the better control. Thank you.
Thank you, Dr. Udita, for that extremely informative presentation. I think we should go for the Q&A session and then go for the other lecture, because we have a little bit of time. If there are any questions, you can ask.
We can go for the Q&A session and then go for the next lecture.
Right. The question is about biosimilar. I think it's extremely an important topic. I think these people are also having a biosimilar insulin for glargine. Now, when you say biosimilar, majority of the people think that it's a generic. If you look at the metformin, the original is glucophage. We have lots of generics, like, different names. So those are called generics. Now, biosimilar is completely different concept. It's not a generic of a glargine. So glargine is the original molecule, but that molecule is quite different from whatever the biosimilar. Biosimilar is not a generic of a original molecule. It is a different molecule, but similar effect. So when you look at the effect now, if you look at the glargine and their biosimilar, which is available in Sri Lanka now, there are two molecules. There are few differences in the molecule as well. Therefore, it's not the identical molecule. But when you look at the blood sugar control, outcomes are similar. Therefore, biosimilar is huge money behind the biosimilar as well. Now, a generic is just a copy of a original thing. So you need not to spend money on any research, anything. But biosimilar, you need to produce the molecule and sure to show the efficacy comparing with the original molecule, which is a glargine. So they have comparable, similar outcome with the glargine. Therefore, it's almost same as glargine. But only difference in registering biosimilar is you need not to go ahead with a cardiovascular protective study, because we know that almost all the medications for FDA approval should go for a cardiovascular protective study or to show that there is similar in cardiovascular. But when you are outcome similar, you need not to show that to show that there is a cardiovascular protective effect. So biosimilar and generics are quite different. Even in US now they are buying hugely a biosimilar because it is cost effective and almost very effective medications.
One question. Instead of giving the insulin 3 times a day, is it possible to use a product like Acabose?
Yeah, now Acabose, now if you look at, it's a quite expensive medication as well. It's not very cheap, right? It's not very cheap. But if you look at Acabose, it will reduce your postprandial blood sugar by about 20 to 30 milligrams per deciliter. And if you look at the fasting blood sugar, when you look at postprandial blood sugar reduction, about 20 to 30 milligrams per deciliter. And you know, the fasting blood sugar is only about 20 milligrams per deciliter when you reduce your postprandial. Therefore, if you have got a patient who has got a postprandial blood sugar of 220, the Acabose has no place because it only reduced about 220. Therefore, according to your postprandial blood sugar, you can think of whether you are going to use the Acabose or not. It's not a very cheap medication. It's quite expensive. Only reduce about 20 to 30 milligrams of deciliter postprandial blood sugar, and therefore you need to think whether it's worth giving it. But in some circumstances, yes. But if the patient's blood sugar is like postprandial is 190, and if you want to get it about 170, yes, that's quite good. You can get it there. But if your postprandial is like more than 200, the place of Acabose is not there.
Udit, it was really interesting. You were telling when the HbA1c level is coming down, the contribution of the fasting blood sugar and the postprandial blood sugar differs.
Yeah.
Right. But then there are certain cases clinically in our experience, right? Sometimes it is extremely difficult to manage the postprandial blood sugar rather than the fasting blood sugar. But then, according to your concept, you said it automatically comes down.
Yeah.
But then, how do you explain the situation that there are certain cases like that, at least where we find it difficult to manage that part?
Yeah. Now, what I said was like, you know, if your HbA1c is higher, the impact is more with the fasting blood sugar. So if your fasting HbA1c is like 12, 12.5, the fasting blood sugar is the more impact. Whenever you get the fasting to the target, that is 90 to 130, your HbA1c will drag down to 12.5 to 8. But when your HbA1c is like 8, 8.5, 7.5, then the postprandial blood sugar is the more important thing. So when you have a fasting blood sugar of 130, and if your ppb is like 400, that's also not compatible. You know, the patient is, you know, either, you know, patient is not taking it properly, and majority of the time that is happening. You know, we rarely do a postprandial blood sugar in patient. I of course never do. Usually I do in patients who are having pregnant only, because the guideline is such that you need to get the all three postprandials into the target. Majority of the times in my practice, I very rarely do a postprandial because it's very difficult to do, because it's going to be artificial most of the time, because whenever if I want to do a postprandial, I usually eat a very little and go and do it. So my postprandial is going to be less. But if I get the fasting blood sugars to the target, and if I get the HbA1c slightly higher than that, then I know the impact is going to be a postprandial. Therefore, I'm trying to get the main meal sorted a bit to get the HbA1c to 7. When you have a higher postprandial blood sugars, patients come to the clinics and they eat from the canteen, then go and give the blood sugar, so it can be very high. Sometimes they don't take the morning meal, morning tablets, and go and give the postprandial, so can be high. So something like that. So be careful about the postprandial. the importance of postprandial in terms of managing type 2 diabetes is less, but we know that the postprandial blood sugars are important in cardiovascular risk more than probably fasting blood sugar. That you need to understand separately. Fasting blood sugar probably less important in terms of cardiovascular outcomes. Postprandial blood sugar is extremely important. But if you get the HbA1c 6.5 to 7, you automatically all the targets are achieved. Yeah, GLP-1 is actually one of the best medications. One of the best medications. If you look at the SGLT2 inhibitors and GLP-1 are the best in the pipeline, I suppose, for us to use. And if you look at the when you look at the selection of SGLT2 inhibitor or GLP-1 after metformin is very well identified. When you have a existing cardiovascular problem, then the next option should be definitely should be SGLT2 inhibitor or a GLP-1 analog, because all the studies, the GLP-1 and SGLT2 inhibitor has shown if you're having an existing cardiovascular problem, the outcome is going to be extremely better in terms of cardiovascular disease is either a GLP-1 analog or a SGLT2 inhibitor. And also, if you have an existing renal disease, GLP-1 analog and the SGLT2 inhibitor is the next option for the patients, because that is going to be the best outcome in terms of outcomes. So in GLP-1 analogs, the common analogs are injectables, which are going to be a problem, but we have a good tablet is going to be come out with the semaglutide once weekly, which is almost similar to the once daily injection of liraglutide. So semaglutide is going to be probably available in next year in Sri Lanka. Going to be a one tablet once weekly, which is excellent and probably almost similar to SGLT2 inhibitors. Now SGLT2 inhibitors are quite cheap in Sri Lanka. You need to understand, about now 40 to 60 rupees, and one of the best to use. And you are reducing your cardiovascular risk, and you are reducing your heart failure risk, and you are reducing your renal problems, even from microalbumin, normal albumin to the microalbumin to macroalbumin to the established renal disease. All SGLT2 inhibitors and GLP-1 analogs are beneficial. So I think this is going to be SGLT2 inhibitors are almost trying to come up to the metformin, almost there. I think when you look at the metformin and SGLT2 inhibitors separately, the cardiovascular benefits definitely better SGLT2 inhibitor. Renal benefits definitely SGLT2 inhibitor is better, and even all-cause mortality is definitely SGLT2 inhibitor is superior, but SGLT2 inhibitor has less long-term data when you compare metformin, and metformin is cheap and available for everybody. That's why still I think it's hanging on the first place, but I'm sure that next 3 to 5 years time, probably things will change.
Are there any more questions, please? Thank you very much, Dr. Bhutat. It's a token of appreciation for your resourcefulness. Thank you very much. Before we move on to the next speaker, there's a small video. To be
telecast. Can you please do that quickly?
From the world famous pharmaceutical giant Lilly comes a new insulin with the efficacy of a gentle giant for your patients. A new addition to Lilly insulin for your diabetic patients, Abisagla. Approved by regulatory authorities in over 70 countries. Abisagla has identical amino acid sequences to its originator and similar pharmacokinetic and pharmacodynamics properties. Abisagla provides similar HbA1c reduction in both type 1 and type 2 diabetic patients to its originator. A similar rate of hypoglycemia to its originator in both type 1 and type 2 diabetic patients. daily dose of Abisagla provides similar efficacy and safety in treating your diabetic patients. The overall clinical profile of Abisagla is similar to its originator, and it's more affordable for your patients. Abisagla, prestigious product from France.
Okay, we'll be moving on to the second speaker in the agenda. That is Dr. Tilak Silla, who is going to tell us about management of a smoking patient. Dr. Tilak Silla graduated MBBS in 1991 from Chittagong Medical College and did his internship at Chilau Base Hospital, post-internship Nigamba Hospital, and the postgraduate qualifications Diploma in Family Medicine, University of Colombo, and member of College of General Practitioners. Presently a full-time primary care physician and special interest in respiratory medicine. And he is also currently the president of ACRJ and a council member of IMPA. And of course, he's also the course manager of the certificate course in COPD and asthma. Over to you, Dr. Tilak.
Thank you, Dr. Ananda, for giving me the introduction thank you so much. First of all, thank you for the IMPA for giving me this opportunity to talk a very important topic today. Being COVID going around, where we have seen a lot of COVID victims who have been complicated, has been died also are smokers. So this it's a timely, I think, opportunity that I got today to give you a presentation how to practically approach your patients in your day-to-day practice and to help them to quit their smoking. So let me start my presentation. Right. Excuse me, it's not coming here. Right. Sorry, there are some technical delays. Well, on my presentation today on this, oops. Yes, in learning objectives in my presentation. So first of all, I like to emphasize on the adverse effects of tobacco use. No, it's not the slide. Describe the adverse effect of health of tobacco use and why we should tell our patients why they should stop and accept the benefits of quitting tobacco, as well as use the 5-way approach to help the patients to quit. I think there's something wrong. I'm sorry.
You can watch that one.
Okay. Can you put? Are you? Unsuccessful. Mata mechanical. So the next one. So the learning objectives, as I mentioned earlier, is describe the adverse health effects of the smoking, as well as for tobacco users, as well as the people around tobacco users, and the why the people smoke and why they should stop, even why they should not. So we have to check both the sides of the benefits as well as the non-benefits for the smoking cessation. And we have the approach called 5A approach, as well as 5R approach on the patient in willing to quit, consider of their smoking. Next, please. It's coming to other one, next. Other one. So how we could help our patients to quit tobacco use? So there is a method called 5A approach on the patients who want to quit smoking, called 5As. I think I will see the pad and do it without just, yeah, without. Let me go for
Don't look at the time.
Okay.
Just leave it.
It's called the 5A approach. 5A approach. There are 5As. So what are the 5As? The first 5A is the ask the patient. Other one is the access the patient, advise, assist, and arrange. Those are the 5As that you should approach on the patient that who want to quit smoking. So first we'll ask the patient, are you smoking? So this is one common error that a lot of private practice, doctors do, they don't ask the question. So when they come for any ailment, we just only try to handle only that ailment, not without asking, are you smoking? So this is a simple question that we can ask from our patient, are you smoking? Then in that way, then we make blood pressure and blood sugar, whatever it is. So the question asking, then we come onto the other stage is, how long you are smoking and how many cigarettes that you are smoking per day. And the previous, have you tried to attempt any quit of smoking and how many times? And at the same time, what are the reasons if you have tried to quit your smoking and this you have failed, right? And would you like to start think of quitting your smoking? So those are the things initially you should ask. Then we'll start the advice. So first, after asking those questions, we have to, as a doctor, has to advise the patient, look, my dear, you need to stop your smoking. So then every tobacco smoker, we should make a point to ask, please stop your smoking because it affects you, not only you, your people around also smoking affected. So please stop your smoking. Just make a request on that. It has to be done on a very personalized manner. As primary care physicians, I'm sure most of them primary care physicians here, we have to be very personalized movement. We're just not talking, you better stop your smoking. No, you have to go it very personalized, very intimate matter, giving advice and giving requesting to stop your smoking on a very personalized manner. So that message has to be very clear. Right. It has to be very clear and it has not to be very lengthy, very short, within such a way that it really goes into the heart and soul of the person. So as a clinician, so we can tell them, ask him to offer how we can help the quitting smoking. Just asking to stop is not enough. Then we should offer them how to smoke cessation program. As I mentioned earlier, it's a very personalized. Then after that, we start assess the situation of the patient's level of smoking. Then the willingness, how much the willingness that patient want to quit their smoking. Is it okay, doctor? I may not now, maybe we'll talk it on our next consultation. So on that level, we will get an idea. Okay, this person is willing, not now, maybe later. So we'll give him another breathing chance on his next consultation. So we can make a kind of a timetable at the same time, how we can quit the smoking in that method. So especially there are cases that we should emphasize on, especially adolescents, patients who have cardiovascular risk factors, diabetes. Those patients, we have to be little bit more aggressive of asking them to quit their smoking. So there is a cycle when we talk about the quit of smoking that is called pre-contemptation, contemptation, preparation, action, maintenance, and the relapse. This is the cycle that usually goes. So pre-contemptation means you're asking the patient, are you ready? Then you're preparing rather patient, like priming the patient to start the smoking, quitting. Then the patient fix a date and start his program of quitting smoking. You prepare the patient, we start the action. So after action has been started, so the most important thing is we have to maintain that action. So during that, there could be a relapse, but still you have to be patient along with the patient and sail with him in such a way that you will not lose the patient on this quitting smoke program. So during that program, there are 4 things that we should consider with the patient. We should discuss. One thing is, what are the good things about using tobacco? Good things. Other thing is not so good things about using. Other one is good things about giving up. Other one is not so good things about giving up. So there are 4 things. We should not tell the patient stop only just because of this. We should discuss plus minus in the both sides. So we'll say what are the good things about using smoking. So what are the good things? What the patient feel? It gives a pleasant and enjoyable feeling, and you relax the patient, reduce the stress, and it's a pleasant, unpleasant experience has been reduced. Then patient gets stimulation of his work to do like that. There are a lot of benefits. We should discuss openly with the patient and reduce the anxiety. Those are the positive things. That's why they are smoking. So other one is not so good things about smoking. So what are the, yes, not so the smoking, sorry. So then we can talk about the cancers. We, as you know, as you quite correctly know, the lung cancer, the bowel cancers, gastric hyperacidity, esophageal cancer, renal cancer. So then we should talk about them. What are the not so good things about the smoking cessation, and what are the benefits? We reduce the cancer as well as the other risk factors, not only to him, even to the people around. So then we will discuss a little bit about what are the carcinogenic effects of the cigarettes smoking. So there are a lot of carcinogenic effects like which contain on the nicotine, like benzopyrene, like there are few which I like to emphasize, like formaldehyde, benzene, even cadmium, chromium, arsenic. Those are the things that effects contain in the fumes of the cigarette. So we'll come to the lung cancer. What is this percentage of lung cancer reduction on this patient? The people who are smoking right now has at least 3.6 of average percentage of getting lung cancer than the person who doesn't smoke. So there is a theory which we always tell, even if you stop smoking of a patient several years, we can return back their health condition as like a non-smoker. Because a lot of people, when they come to us, they ask, doctor, I've been smoking for last 20 years. If I stop it today now, what will happen to my, which have been damaged? Very confidently, you can tell the patient, don't worry, my dear, you stop today. Within another 5 to 10 years, you will be like, just like you had never smoked. It has well proven, well documented. So that's a very positive point that you can emphasize on your patient. So then at the same time, I cannot show certain graph because it's not presenting here, but I will just say you what are the effects on smoking on the skin. The patient get the wrinkling of the skin, darkening of the skin, even the nails will be damaged. So the wound healing, other thing is the wound healing. There are a lot of patients with the smoking, their wound healing is very poor. So you can tell the patients, if you stop your smoking, even your chronic wounds heal fast. Even if you had a surgery, the wound healing will be very fast. So then other one I just want to emphasize is the side stream smoke, which is something very important that you have to talk. When a person takes a cigarette into the hand, there are two types of smokes coming out of the cigarette. One is the cigarette smoke that comes through the filter to the mouth. Other one is the cigarette smoke which come out from the cigarette. That is called the side stream. Especially the side stream smoke is very toxic, more than the smoke what the patient inhales. So please tell your patient, because if they are holding a cigarette in a place without even smoking for a few minutes, perhaps the smoke that comes out from the side, it is very, very toxic. It deposits onto the garments as well as other one. So we call it, that is not third hand smoking. So please emphasize on your patients, you are smoking, when you're smoking, your side stream, the smokes which come out of the cigarette is very toxic, which lands onto the surface, and a person, even a child who touch that smoke, that nicotine, can get absorbed from the skin. So we have seen a lot of third hands, we call it third hand smoking. Those days people are talking about first hand, second hand smoking, but now we call third hand smoking, especially if they have any furniture in the house, what we call even the vehicles, when the smoke deposits on there, that can be absorbed through the skin. That's why even nicotine patches. Right, you got it right. Yes. Thank you. One. You see here, the cigarette is here. We can find the side smoking. So it contains very toxic, more than the smoke goes through the filter. As you mentioned, it goes to the filter. It at least filtered. Here it is not filtered. Next. This is the second hand smoke that we always talk about. where the patient exhale when the other people inhales, so that we can have the second-hand smoke on these patients over here is 20 to 30% of lung cancer risk. So we talk about second-hand, now third-hand smoking. Next. So these are the third-hand smoke, as I mentioned earlier. Even those things surface on the skin, hair, clothing, and furniture, and which enters into the people who touch those things and give complication, effects, bad effects of the smoking. Next. Next, please. Yes. So this is the common question the patient, doctor, I'm smoking for a very long time. If I stop now, it will be reverse the damage. We can say yes. With confidently, you can say yes. Right. The statistically I have mentioning you, if a patient starts cessation smoking here, after 3 months, his lung functions improve. It decreases cough, sinuses. After 1 year, you can see his chronic heart disease risk reduced by 50%. After 5 years, risk of level of people having never smoked, almost 5 to 50 years, just as equal as that. 10 years, lung cancer risk is reduced to 30 to 50%. After 15 years, as if coronary heart disease, as he has never smoked. So you can show this chart how a person who stops smoking can reverse their benefits in their life. So early quitting is effective. Okay, next slide. So what are the additional benefits of quitting? Benefit of quitting smoking. So it improves reproductive health. It improves the recovery from any surgery if he has to do, and the other improvement of health benefits to other people who lives around his house, and especially the children, the parents who are smoking, for the children who are in the household, they are also hugely benefited if they are asthma and so forth. Next. Then other one is I should stop smoking because these are the reasons you can always tell. I feel better and I feel breathe easier. I cut down the risk of my other illnesses in future, like diabetes, even coronary heart disease. Then I live longer. Food, and the other thing is food. The food tastes better. My appearance will improve. The bottom smokers, they have their wrinkles appearing in their face. Their nails are getting dark. So those are the things that they will be get improved with. Next. So what are the not so good things of giving, not so good things about giving up smoking? Yes. Next. Those are the not so good things of giving smoking. One thing is nicotine reaches brain within 10 to 16 seconds of inhalation. It reaches the brains. So this is the pleasure that the people they will lose. The relaxation, reduce stress, increase alertness. Those are the things, positive reinforcing of the nicotine on the patient. Next. So these are the addiction triangle of the patient who is a smoker. It's behavioral thing and psychological and physical. That's the triangle that always you have to keep in your mind, or the patient who's addicted to smoking. So other thing is we should like to talk is nicotine withdrawal. So usually nicotine withdrawal symptoms, the carving immediately start within, let's say, hours. What is the carving, the effect, the liking of the cigarettes, nicotine come within effects and slowly increase within 3 to 4 days. And the most important thing is it slowly decreases. The first few weeks only, the patient will be having the problem of carving of the nicotine. Within 1 to 2 3 weeks, slowly it reduces. Within 3 to 6 months, it's very much reduced. So withdrawal from nicotine, what are the symptoms? You see, peak relapse is very few, then slowly it tails off. You can see it's very short living. You don't have to worry, you have to go for long hours. But appetite in grade will be slowly putting up. And the carving also go for 10 weeks, then slowly that will also be withdrawn. Next. So what are the withdrawal symptoms? When you ask the patient to stop smoking, what are the withdrawal symptoms? So you'll get the irritability, insomnia, the increased appetite and weight gaze, the depression, difficulty in concentration. Those are the things, anxiety. Those are the things that we should discuss with the patient when you start giving advice on smoking cessation. Especially the appetite increasing is something that a lot of people have. So knowing the harmful of tobacco, how we do about getting patient to quit smoking. Next. Then we assess. So we'll take the level of addiction of the person. Then we'll ask what is the reason that you keep on smoking? And with the same time, what make you fail the last attempts of quit smoking? And what are the costs that causing you the smoking? Even that cost also something we should discuss about. Next. So this is a Ferguson questionnaire that with this questionnaire we can assess the level of person smoking addiction. So do you see there are questions how soon when you wake up, how many cigarettes you want to take, and what do you find difficulty in taking cigarette to concentrate on that. So this is called Ferguson questionnaire. With this question you can download from your computer. Then this questionnaire, you can get an idea how far the patient has been addicted to the cigarette smoking. Next. So if the Ferguson score is less than 7%, we can consider low addiction. If it is more than 7, we can say high addiction. So we can just get a rough idea with the Ferguson questionnaire, how can we manage this patient's smoking cessation. Next. Right. So in this Ferguson questionnaire, if you decide high, moderate, and severe, so then we can think of what the patient we could, either we can go for patches or we can go for lozenges or whether like that, there's a combination therapy. So we have found out combination therapies are very effective on the patient who are addiction to smoking in their cessation program. So with the Ferguson questionnaire, you can think whether you can use the patch, the lozenge, or a gum. So those are three methods that we can substitute nicotine in the patient when they are ceasing in the program. Then we should talk about what are the reasons to fail the previous attempts. Next. Next. Right. So when you can see on this graph, so what are the advice? You see, when you see this graph, the length of the time that we intervene with the patient, you can see the length of the more the length of the consultation, the higher the cessation successful. Then the number of sessions, you can see the second one of your consultation also increase. As the whole, when you talk about this, you can take this to very importantly the time as the encounter times, how many numbers of sessions, the more the sessions, the more the successful of your successor take patients smoking cessation. Next. So we can have the self tips, then a brief opportunity session, individual, we can groups, we can ask, there are persons who can, they can make groups and they can start smoking cessation, and we can take certain behavioral approaches like management of in group and as well as relaxation methods, as well as pharmacological intervention. So those are the basic approaches that we can assist our patient on quitting smoking. Next. So when the patient is starting the quit date, we should ideally select a date, let's say within 2 weeks of time. Then ask the patient to tell the family, their relations, okay, there are people, okay, from next Monday, I'm going to quit my smoking. So then everybody is aware. So then at the same time, we have to ask them to remove all tobacco products from their home. Their cigarettes, their lighters, and the ashtrays out of their sites. So that's very important to make the environment friendly for their quit of smoking. Right. Then we can advise them on the practical points, like there is, we call it abstinence with total abstinence, not even single puff. Some people think that Okay, doctor, I will cut down, but there is nothing called cut down. You have to stop smoking. You have to tell your patient, my dear, you have to stop your smoking immediately. There is no cut downs, right? Then you do the next one, please. Right. So these are the 5D help to fight the carving. The moment the patient stops smoking, these 5D methods will be very helpful now to the patient to reduce his nicotine carving. One thing is delay. Delay the interval of the time that the patient is getting to get that carving. Delay. So the delay, the more you the delay, the less the amount of impulse that patient getting to stop their smoking. Other one is drink water or eat chewing gum or something like that to keep the mouth occupied. So when the person, when urged to get a smoking, ask the person to get a small glass of water and get small sips for about say 15 to 20 minutes. So the mouth is occupied with water, so he will not have opportunity of taking the cigarettes on his mouth. And distract yourself, ask to do something that the patient like. Sometime maybe go out, maybe talk to a friend, and take a deep breathing. It's called relaxation method. And one is called the support, or maybe the patient must be having a friend who is helping to quit smoking. Ask the person to give a call to him and tell him that, look, my dear, I have a urge of getting, can you just, then you just talk, he will help, don't worry, just take your time. Those things are very helpful. So these are the 5 Ds you can tell your patients to fight the carving of nicotine. Next. So those are the things that we have to tell them. There would be some constipation. So for that, we can ask the patient to get a lot of high fiber diet and tell the patient you might get because of weight gain because the appetite is going to increase. So then ask the patient to do exercises or avoid food that increase the weight. Other than is never store a cigarette, lighter together in your place or whatever it is. Because always when the person see a cigarette and a lighter together, they always tend to light a cigarette and smoke it. So those are the few practical tips that you can give unto your patient. So other one is specific challenges because alcohol. Some people we have found out alcohol is a stimulation to person to take smoking. So we should ask them to stop taking alcohol. Because sometimes some patients tell doctor, I'm okay, but when I want to get an shot, drink, I always want to start a cigarette. So you should ask this person to avoid smoking. Alcohol. Right. So at the same time, there are officers, there like some people, spouses, like friends, who are willing to stop smoking like a group. Let's say there's a person, he's in same office, he say, friend, I also want to quit smoking. So they can stop smoking as a group. That's also very effective. Next, please. So then we got to, first of all, I'll just little talk about the non-drug approach as I tell you. First, we can do a cold turkey type of approach. Preparation for external help, just immediately stop it. Other one is practical counseling, as I mentioned you earlier. And at the same time, group support as well as behavioral therapy. Next. So then we'll come to the pharmacotherapy. The pharmacotherapy, the medicine that we can, pharmacologically we can start is bupropion slow release. So that is available in Sri Lanka, which is help the patient to quit the smoking. Other one is nicotine replacement therapy. Nicotine gum, nicotine inhaler is there, nicotine nasal spray, and nicotine patch. In Sri Lanka, what we have available right now is nicotine gum. We don't have inhaler or spray. Nicotine patch was available sometimes, but not available. So these are the medication as well as other nicotine replacement therapies available in Sri Lanka. Next. So in the nicotine replacement therapy, you can see the gums, lozenges, patches, nasal sprays, as I mentioned, available. Sri Lanka, we have only the gums. Next. So nicotine replacement therapy delivers the nicotine gradually reduces nicotine levels throughout the day. Right. So without much of nicotine replacement, when we give that in, the patient doesn't have much of a carving that has been doing earlier and will be neutralized. So we have to think of that mechanism when we give the nicotine replacement therapy. At the same time, increase the ability to nicotine medication in the nicotine receptor. So when there are nicotine replacement as well as the pharmacology, there is a very highly beneficial effect. Next slide. I can just mention here on this graph, previous slide, little bit, previous one. You see, I mean, when you take about the gum, you see gum is this how the level come. This is the normal smoker cigarette, but we cannot reach the same level, but we can come at least with gum with certain amount of nicotine replacement during the cessation program. Next. So nicotine gums have two strengths, 2 milligram and 4 milligram. So 50% is bioavailability. So with the dosing, where the patient is making less than 15 cigarettes, we can give about 2 milligram dose of gum. Unless more than 15 cigarettes, we can give 4 milligram. So if we can fix a schedule, as I mentioned earlier, previous gum, yes. So every 1 to 2 hours for first 2 weeks, then 2 to 4 hours, 3 weeks, like that, we slowly increase the interval. We can make the additional gums if there's any breakthrough. Next. The nicotine patch, although it's not available in Sri Lanka, I just want to mention what is availability. So it's about 24 hours is releasing. It is available 7, 14, and 21 milligrams. So if the patient is taking more than 10 cigarettes per day, we can start a 21 milligram patch, then you can keep in the body for 24 hours. As I mentioned you earlier, nicotine patch is absorb nicotine through the skin. As I mentioned, third hand smoking, as I told you, that also go through the skin. So this always, there's a very close relationship. If there's a breakthrough carving, you may need another extra. Right. There's another thing about e-cigarettes. A lot of patient ask from us, doctor, can I switch on to e-cigarette? But please say don't. It is not a substitute. It's well documented. Next. So as I mentioned, bupropion is a drug of choice at the moment available in Sri Lanka to stop smoking. So it is a dopamine antagonist as well as noradrenaline reuptake inhibitor. It has the effect of nicotine withdrawal. It decreases nicotine withdrawal as well as reduce the carving. So there has double action of giving bupropion onto the patient who is smoking presently. Next, please. So this is very important thing. You should not start smoking cessation programs to give bupropion on the day of they are planning to quit. You should at least ask little about 3 to 2 days prior, at least 3 to 4 months. Ideally 1 week before quitting date, the patient should start the bupropion. Then continue it for 7 to 12 weeks, even after quit date, and we have to maintain it for 6 months. If there's no significant improvement within 7 weeks, we can discontinue, but there's a high chance that the patient will have a very successful cessation of smoking with bupropion if you really continue it for 6 months. So what are the side effects? Those are the dry mouth, insomnia, and the seizure if the patient is epileptic. But other than that, there are no very problematic side effects of bupropion. Next. So efficacy is quite efficacy when you combine with the patch, right? When you combine with the patch, nicotine patch as well as bupropion, the patient has a very good effect on the smoking cessation. When you 1 year follow-up study demonstrate both 150 and 300 milligram placebo, we can find the combination therapy with nicotine replacement has a very high chances of successful cessation. Next. So these are the adverse effects of bupropion. As I mentioned earlier, it reduces the threshold of seizures if you are treating a patient with epilepsy. And so you don't have to much worry about it. But if the patient is not epileptic, definitely we can start bupropion on the patient on smoking cessation program. Next, please. So other side effects are the insomnia, agitation, dry mouth, headache, Those are the other side effects. These and the bupropion is quite safe. The patient with coronary vascular disease as well as COPD. So with the patient with COPD, coronary vascular disease, you can prescribe bupropion. You don't have to worry about it. Next, please. There's another medication called vernicline, but it is not available in Sri Lanka. For academic purposes, I just want to mention this is how we start. 0.5 milligram once daily, just before the quit date. Then 4 to 7 days, slowly step up the dose. At the quit date, you get the quit date and just continue from there, or at least about 2 weeks. Even after you can continue even 12 weeks after medication, after the continue of the quitting period. Next, please. I think I don't know much about metabolism because since it's not available, we'll go next. Next. So the choice of medications, primarily, we have to talk about adverse effects. Contraindication, we have to consider psychiatric, what are the other psychiatric problems, what are the current medication, the cost, the patient preference, and prescriber confidence. Those are the things when you should think when you're starting pharmacological management on a patient of quitting smoking. Next, please. Previous one, please. Previous. No, the one next. Yeah, just hold on. So when we talk intervention, when we talk about intervention, what are the odds of ratio on successful? When you see the doctor's brief advice, here you can see it's quite effective, 1.3 to 1.74. So we always tell, take the intervention and ask the patient to stop their smoking during your consultation. So when you think bupropion also have a fairly high rate of success in quitting smoking. So these are the methods which has been showing quite effective on cessation of their smoking. Next, please. You see, when you see with this slide, you can see even no action with the age grows on, there is a tendency to stop smoking, even if no action has been taken. So medication, of course, there's a high chance of successful of quitting. When both the action, medication and behavioral support has a very high success on their quit smoking as the age goes off. So the time is a healer on the smoking cessation as well. Next, please. So in all stages, the patient education is very critical. We have to get the positive feedback in all stages from the patient. Advise patient to reward himself. Whenever time he pass, advise the patient, okay, I'm successful, I should continue. Just like a positive feedback, get the patient to reward himself during the process. Next. So after that, we can arrange follow-up, then we can start supporting and ongoing, and we can monitor the carboxyhemoglobin breathalyzer. There's a machine. We can measure the level of carbon monoxide in the blood. But if the patient is very genuine, you don't have to have that machine. But it's a very simple, like a breathalyzer, you can find the level of carbon monoxide. You can tell the patient, look, see, your carbon monoxide level of the blood is coming down. So that we can tell by that breathalyzer called carboxyhemoglobin breathalyzer. So the key messages: ask, advise, assess, assist, and arrange. As I mentioned earlier, these are the 5 A's in management of quit smoking. Next. So if the patient is not willing, let's say there are some patients not willing. So how could you handle those patients? So there are 5 R's. So we talk to the patient, relevance as to the patient, the quit smoking, and the risk. We can talk about the risk. Then we can talk about the rewards of the smoking on that patient. So what are the roadblocks? What are the obstructions that you don't want to stop smoking? And the repetition of advice is very important. You don't have to stop. Just keep on telling the patient whenever he comes for your consultation, repeat the advice of a patient who is not willing. So at the point down the line, he will accept your advice and start quitting. Next. So as mentioned the cycle earlier, there is a pre-contemptation, contemptation, preparation, action, and maintenance. So this is a cycle which usually occur during the smoking cessation. So we talk to patient, he agrees on that contemptation, then we prepare the patient, start the action. When maintenance, so there could be relapse, Right, but still you can ask the patient with it's like a joint hand-to-hand method. We can go on this cycle during the cessation of smoking. Next. So in summary, there are 5 A's, 5 D's and 5 R's. So what are the 5 A's? As I mentioned earlier, ask the patient, give the advice on patient, assess the level of patient's willingness to smoke, then assist the patient and arrange the smoking cessation program. So these are the 5 A's in the beginning. During a consultation, you can talk. Then the 5 D's to help fight the carving. The moment the patient stops smoking, he will have the carving. So how you can ask your patient to reduce the carving and fight the carving? Those are 5 D's. Delay the urge, drink water or something, keep the mouth occupied, do something else, distract your mind, take a deep breath and just do some breathing and relaxing exercises, and discuss your feeling with the person who's helping you in this smoking. It could be a doctor, it could be a friend, your wife, whoever it is. Those are the 5 Ds. So these are the 5 R. If the patient who is not willing to commit the smoking cessation, ask why it's not important to you. And one is talk with the risk factors of the smoking on the patient. Then tell the rewards. What are the benefits you will get because of your quit smoking will be rewardful. What are the roadblocks? What are the obstructions that you think you don't want to smoke? Discuss those points, and we repeat the same thing whenever you meet on your next consultation with the patient. Next. So the last in the take-home message is tobacco is the last preventable cause in health problems. It represents the biggest single step that person can take to improve the quality of their health. Nicotine addiction is the strongest of all substance addiction. So you can see how bad the nicotine addiction can distort the person's life and their body and the mind. Patient addicted to nicotine helps to quit tobacco use. The best results are achieved in combination of multiple approaches like psychosocial support, nicotine replacement, as well as pharmacotherapy. Prolonged follow-up and support is needed to prevent the relapses. Useful guide in the patient to health professionals through the tobacco cessation process are 5A, 5D, and 5Rs, as I mentioned in the previous slide. Right. Thank you so much. I'm sorry for inconvenience during my technical errors. If you have any questions with regarding to my presentation, I'm ready to answer.
For that very practical presentation. So session is open for Q&A.
Are there any?
If there are no questions, I think we can. Dr. Tilak, this is
Thank you.
mark of for you being a resource person for us. Thank you very much. Okay.
Thank you very much.
IMPA President Dr. Anand Perera, distinguished resource persons, ladies and gentlemen. It gives me great pleasure in proposing the vote of thanks this evening at the end of this very useful continuing medical education program. At the outset, on behalf of the President and the members of IMPA, let me extend our grateful thanks to the two resource persons, Dr. Udita Buligapitiya, consultant endocrinologist, and Dr. Tilak Silva, the family physician, for sharing their experiences and giving us a very useful and timely presentation. Then let me thank all of you, each one of you, for joining us this evening here at the OPA, and also those who joined us online. I say a big thank you. And last but not least, a very special thanks to our generous sponsors, Hema's Lilly Alliance, Hema's Pharmaceuticals Limited, for their sponsorship of this evening. All are invited for fellowship and dinner, and let me wish you a very pleasant evening. Thank you very much.